it's now dropping to around 11%. Even the duration of responses are not very high. Like I said, the triple negative breast cancer is kind of like a diagnosis of exclusion, and all triple negative breast cancers are not alike. So we have a range from low grade tumors to high grade tumors, and we don't have to be super scared about every TNBC that we see. And from the pathology point of view, when you see an secretory carcinoma, adenoid cystic, these are unusual pathologies of breast cancers. They are triple negative, but they are actually better prognosis. So what we are trying to do is to understand if there is what is the heterogeneity that is there in TNBCs, and this is the gene expressions profile of triple negative breast cancers. And as you can see, there can be a varieties of gene expression, and how to understand this and use this to treat our patients and improve response rate is where the active research is going on right now. As of today, there is no clinical use for this gene expression profiling for TNBCs, but hopefully, with the better understanding, we will know how to treat them. So, the treatment as such remains chemotherapy. This is the main treatment of choice for most patients with TNBC, especially in our settings where we don't have too much access to the other drugs. So I have spoken about chemotherapy agents in my first class, also about metastatic breast cancer, but I will touch briefly upon each one of them and their role in TNBCs as such. So, as we know, we use a lot of chemotherapy agents, starting from anthracyclines and taxanes to all this that is there in the list. And the choice of chemotherapy again depends upon the patient's factors, the disease factors, and the prior treatment history, what the patient wants, and what we think will be best in that particular situation. So, treatment is highly individualized for patients with metastatic TNBC. Coming to anthracyclines, we don't use them much in the metastatic setting because most of our patients now would have received it in the adjuvant setting. But definitely not forget, we should keep them in mind when we see a patient with the de novo breast cancer. The common agents are doxorubicin, evirubicin, and liposomal doxorubicin. And the weekly regimens, which we don't use in India again commonly, and in Europe it's fairly common, are probably better tolerated and have the similar response rates. So again, for patients, this is something to think about: weekly doxorubicin or epirubicin, and overall response rates are anywhere between 30 to 50%. Now, there was a study which looked at liposomal doxorubicin. This was a non-inferiority trial, and and it was found that the overall response rates, survival, overall survival, more or less same in both the drugs. It is the side effect profile which is different, where you're seeing more cardiotoxicity, anesthesia, nausea, vomiting in doxo, and in liposomal, as you know, we see more hand-foot syndrome, mucositis. Keeping this in mind, again, we can plan for the patient what we want to do in terms of anthracyclines. Now, coming to taxanes, again, we use them up in the adjuvant setting. So, unless there is a long duration between the end of adjuvant and when the patient is diagnosed with metastatic, or patient has a de novo metastatic breast cancer, we are not using taxanes much. But the rest, and compared to anthracyclines, which one would I use in first line? The response rates are similar, the survival rates are similar overall, but maybe the toxicity profile is different, and taxane based combinations were better than anthracycline based combinations in PFS, but not in terms of survival. So, this is data from the adjuvant showing that in patients who have triple negative breast cancers, they respond better to paclitaxel, they respond better to the combination TAC versus FAC. So we could extrapolate this data and definitely say that taxanes are very active in TNBC patients. which taxane in the metastatic? Is there a preference? Not much of a difference between the two. Maybe docetaxel has a slight edge, but again, there is a lot of different ways in which you can give paclitaxel, so we can't really say that. More or less similar. Side effect profile is different. For docetaxel, fluid retention, fatigue can be very bad with dosi, myelosuppression, diarrhea. So it's not a happy chemo drug to give. With paclitaxel, we are always worried about the hypersensitivity reactions, and the myalgias can be terrible in some patients. Nab-paclitaxel is also something that we are using commonly because we use up the paclitaxel in the adjuvant setting. No pre-medications required and shorter infusion times, but definitely more neuropathy and hematologic toxicity with nab-paclitaxel. So we could think about 3 weekly docetaxel or weekly paclitaxel are the commonly used taxane regimens. Now, between paclitaxel, and exapipilone, which is an epothelone, when these three were studied and to see which one would be better, paclitaxel was the clear winner compared to exapipilone and nab-paclitaxel. So, still our old drugs work very well. Now, like we discussed, these patients usually have seen anthracyclines and taxanes. So, what do I do when a patient comes to me with metastatic breast cancer after this? So, if I don't think they're eligible for a taxane, it's been very quick after the adjuvant treatment that the patient has developed MBC, then capecitabine is an option. It's an oral drug, and we are familiar with the hand-foot syndrome and the diarrhea, and we know how to manage the doses. We can try the 1 week on, 1 week off schedule. So if a patient doesn't have a high tumor burden, we can definitely try single agent capecitabine. Now, since Erbilin is now available in the market and there are local brands also and has become generic, we are hearing a lot about Erbilin in the NBCs nowadays. We have a lot of these drug reps coming to the clinic talking about it. Is there really any superiority of Erbilin compared to any other drug? So this is the Embrace study where they looked at Erbilin compared to any investigator choice drug where it could have been capecitabine or vinorelbine, and the difference in 1 year survival was 43% versus 53%. So numerically it is better, but not really a very exciting difference. Less neuropathy with eribulin. It can be used in mild to moderate hepatic dysfunction. The infusion times are not great. It's a very quick infusion in the clinic. So definitely we can think about eribulin in patients. This was a study which looked at the eribulin versus capecitabine in patients with metastatic breast cancer who had received less than 3 prior chemotherapy regimens, which means they already got a taxane and an anthracycline. So in these patients, like we discussed, capecitabine is a very standard treatment. And unfortunately, what we found was that there was no difference in the survival between capecitabine or eribulin. So both are equally good or equally bad drugs, whichever way you want to look at it. Now, in a pre-specified exploratory analysis, it was found that the triple negative breast group breast cancers might have a greater therapeutic benefit from eribulin. And uh, this is another analysis which is looking at the eribulin versus capecitabine in triple negative breast cancers. And again, it was found that there might be a slight edge of eribulin over capecitabine in TNBC patients. So here you can see that the median progression-free survival is 13.5 versus 16.1. Sorry, that's the overall survival is improved by about 3 months. So in a patient, maybe we should be using eribulin a little beforehand in triple negative breast cancers. Definitely, it's an active drug and should be thought about. So we have a lot of drugs that they are there: anthracyclines, taxanes, capecitabine, eribulin. What about platinums? Again, when we hear triple negative breast cancer, we hear a lot about platinums. So these are some studies in the stage 4 setting, which looked at carboplatin or cisplatin. And overall, if you see, the response rates are anywhere between 15 to 30%. So it is one more drug that is present in the multiple chemotherapy regimens that we have, one amongst many. And in the meta-analysis that was done, looking with the Cochrane database review, looking at the role of platinums in metastatic breast cancer, if we looked at all breast cancers, that is your ER positive, HER2 positives, and triple negatives, there was really no difference in between platinum agent or using any other chemotherapy. That was one of the conclusions that we learned from the meta-analysis, that there was no survival benefit and it might be more toxic. However, in triple negative patients, there is low quality evidence that there might be an improved progression-free survival or time to tumor progression. And this meta-analysis suggested further randomized trials, but I doubt we will ever have any trials looking at this. So again, data suggesting that in TNBCs, carboplatin and cisplatin, there might be slightly improved response rates. This is a combination of platinum with various different agents. So gemcitabine, nab-paclitaxel, and there is a non-platin regimen also, nab-pacli with gemcitabine. And here we can see that the best progression-free survival in this phase 2 study was seen with the carbo nab-pacli regimen. So if you are planning to use a combination of a platinum with another agent, this is a good combination to be using, and the response rates are quite high. Now, the main thing is, why are platinums sensitive in TNBC, and is there a particular group of patients in triple negative breast cancer who respond better to platinum agents? And that platinum has been studied in BRCA mutation patients. This is a phase 2 study, a Polish study, where they looked at a small group, 20 patients who had BRCA mutation, and when they gave them single agent cisplatin, 75 milligram per meter square, almost everybody, there was a response rate of 80% with a median time to tumor progression of 12 months. So that is a very high response rate that we are seeing in this subset of patients with triple negative breast cancer, and definitely something to be thought about. Now, this is a trial that we should all know when we are talking about triple negative breast cancers. So, this is called the TNT trial. And here, this is a phase 3 trial where we looked at metastatic triple negative breast cancer with germline BRCA1 and 2 mutation. So, these were patients with ER, PR, and HER2 negative patients who had both, sorry, both germline and non-mutated patients also, but they're all TNBC only patients, to see whether really this platinum has an edge or not. So what they did was they randomized patients to carboplatin versus docetaxel to see which is a better chemotherapy to be giving upfront. And at the time of tumor progression, the treatment was switched. So patients who got carboplatin received docetaxel, and patients who got docetaxel received carboplatin. So this was a study to look at the role of platinums in metastatic TNBC. And what did we find? If you looked at the entire population of patients, all TNBC patients, the overall response rate of platinum was actually lesser than that of docetaxel numerically. So this was a 31% response, and docetaxel is 35%. So if anything, it might be worse, but it is definitely not better than docetaxel in the first line setting in TNBC patients. There wasn't much of a difference in the progression-free survival or in the overall survival. So while we talk about platinum in TNBC patients, if we take the entire group as such, there doesn't seem to be any benefit of platinum over a taxane. How about if we look by BRCA status? And when they looked at patients with germline BRCA mutation positive patients, who were about 43 of them, the response rate was higher, 68% response rate compared to docetaxel. So they definitely in BRCA mutation patients, platinum agents seem to be having a higher response rate. So why is it that platinum agents work better in BRCA mutated patients? So just a little bit of biology, don't want to bore you too much, but when we look at patients with uh, BRCA mutations, if you look at the DNA of these patients, Basically, the DNA can be damaged in two ways. Patients can have a single strand break or they can have a double strand break. Whenever you have a single strand break in the cells, it is repaired by the enzyme called PARP. Platinums can cause single strand break. So, if a platinum agent causes a single strand break, it can be repaired by a PARP. Now, when we use a PARP inhibitor, that can no longer be repaired. However, in these patients, there is another mechanism which is called homologous recombination. So, with homologous recombination repair, these strands can still be repaired. Now, if we block both these pathways, how to prevent DNA repair of both single strand and double strand? So, if we use both PARP inhibitors and HR deficiencies, so BRCA mutation patients, ATM patients, then there will be a cell death. So, on the basis of this, we can say that patients who have platinum, where we are using platinum agents, when we use a combination with in BRCA mutation, they will have a better response rate. So that process is called synthetic lethality. So if you have a cell that has a good BRCA, so there is no mutation in the BRCA, there is no problem with single strand breaks either. The cell is normal. However, if the cell has a normal BRCA, but you're inhibiting the PARP inhibitor, again because the BRCA is normal, the double strand breaks get repaired and the cells do fine. If the BRCA is mutated but there is PARP present, again cells do fine. So when you have this combination where you can neither repair double strand breaks nor can you repair single strand breaks, that's when you get a cancer cell death. So you cannot repair double strand breaks in patients who are BRCA mutated. You cannot repair single strand breaks in patients who have either a PARP inhibitor or a platinum agent. So this combination where you cannot repair both the pathways, that is called synthetic lethality, and that is the advantage that we take when we use either a PARP inhibitor or a platinum agent in patients who are BRCA mutated. So does this really work? So let us see. In patients with PARP inhibitors, so these are the two studies that were done. The first one is the Olympiad study, where we looked at HER2 negative metastatic breast cancers who had germline BRCA mutation that was positive. Patients could be either ER positive or TNBC. So this was not exclusively triple negative breast cancer patients, and they had already received anthracycline and taxane. So these are the patients where we are wondering what to do. Should we give them capecitabine? Should we give them eribulin? So in these patients who had germline mutation positive patients, to test the concept of synthetic lethality in the third line basically setting, patients were olaparib was tested against the standard chemotherapy based on the investigator's choice of capecitabine, eribulin, or vinorelbine to look at the progression-free survival and overall response rates and overall survival. Now, an important point to remember is that in these studies, previous neoadjuvant or adjuvant treatment with platinum was allowed, but 12 months had to elapse. So these patients were sensitive to platinum. Similarly, even in the metastatic setting, you could have had a platinum, but the patient should not have had any evidence that disease progression had occurred during treatment. So these are patients who are sensitive to platinum, and here we are testing olaparib versus chemotherapy. Another trial that was done with a different PARP inhibitor, which is talazoparib, and here again these are platinum sensitive patients, and it was again tested with the physician's choice. And what did we find was similar to how we saw with platinum agents in BRCA mutation patient. The response rates are very good when you use a PARP inhibitor. 59% in the Olympiad study of olaparib and 62% in patients in the EMBRACA study. Progression-free survival was also improved and statistically significant. The difference of about 3 months in the Olympiad study and 3 months in the EMBRACA study. So definitely better improved response rates and progression-free survival. So, but some things to remember is that while they have shown better progression-free survival and response rate, we have not seen any difference in survival so far. But overall survival has been a secondary endpoint, and maybe these studies were not powered to look at overall survival. There was a fair amount of crossover also, and also whether maybe these patients received platinum treatment. So there are many things that are confounding in these trials, so we might not really get an answer about overall survival. Also, both studies included hormone receptor positive patients, and there, like I said, there are different uses of chemotherapy in the past and the previous platinum therapy. But the biggest question to ask, especially in our setting, is one, is there a role of PARP inhibitors in platinum refractory patients? And those studies have not been done. Second is, what about just using a platinum instead of a PARP inhibitor? So these are anyway platinum sensitive patients. The same response rates we have seen with platinums in the neoadjuvant setting, we are not seeing them in the metastatic setting in the TNT trial. Why can't we just use a platinum instead of a PARP inhibitor? Much cheaper and might be as effective. I don't think such a study will ever be done, and that question will remain unanswered, but that is definitely something to think about. Now, coming to the next thing, which is immunotherapy. So, for immunotherapy in triple negative breast cancer, two agents have been studied. One is atezolizumab, and the other one is pembrolizumab. So, these have been looked at in the first and second line settings. So, coming to the first line settings, these are patients. This is the Impassion 130 study, where the combination of atezolizumab with nab-paclitaxel was tested against nab-paclitaxel alone. And these are, like I said, first line TNBC patients in metastatic setting. And there was a 12-month disease-free interval from the prior adjuvant setting for these patients, and ECOG status was 0 or 1. So we have to remember this because sometimes we get patients who relapse within 6 months of therapy. Sometimes we get patients with a very poor performance status, and we have to remember that these patients were not tested in this study. And what did we find was that there was an improvement in the PDL1 positive patients. So, in the progression free survival, overall there was not much difference, but in the PDL1 positive patients, it's 5 months versus 7.5 months is the progression free survival improvement. In overall survival, also, you can see that the gap between the curves is much wider in patients who are PDL1 positive, even though till now it has not reached statistical significance. So definitely for patients with atezolizumab and nab-paclitaxel in the first line, there is seems to be a benefit in progression-free survival in patients who are PDL1 positive. It is an FDA-approved drug. We have to remember that the diagnostic test that we do for PDL positive is an SP142, and right now there are only one or two labs I think that are doing that in our country. We do more TPS and CPS scoring, but the SP142 has just come. The second study was the pembrolizumab study, where again pembrolizumab with investigator choice chemotherapy versus placebo plus chemotherapy. And here there was a 6-month difference from the prior treatment in the adjuvant setting. And here they looked at patients who had a CPS score greater than 10, greater than 1, and the entire population. And long story short, what they found was that it was the patients who had the high CPS score of greater than 10 who seemed to be benefiting most from pembrolizumab in terms of progression-free survival. So the median progression-free survival is 5.6 versus 9.7 months. At the end of a year, about 39% of the patients who have CPS score greater than 10 are alive when they are given uh, pembrolizumab immunotherapy combination, which is a very good number for TNBC patients. So definitely we need to be choosing the right population. As your CPS score becomes lower, it looks like the benefit from the pembrolizumab becomes lesser and lesser. What about in the second line? So, if the patient has already come to you after taking chemotherapy somewhere else and now wants to know if they can get immunotherapy in the second line, this is one study, the Keynote 199 study, which looked at pembrolizumab in the second line, and unfortunately, not much benefit from the immunotherapy. However, if your CPS score was really high, there might have been some improvement in median overall survival. So again, there might be a small group of patients, but if possible, we should be giving it, entertaining it in the first line. So in less than 6 months, the pembrolizumab study looked at patients in less than 6 months, and there is the Impassion 132 study where we are waiting for the results to see for the role of immunotherapy there. Why are we so excited by immunotherapy even with the modest improvements in progression-free survival? One is that there might be a group of patients who will really benefit from it, and we're trying to find who that group are. And in all our practices, we will see a patient where they respond so well to immunotherapy and they have been on it for months and months together. So this is showing single agent immunotherapy by response. If you see the overall survival, patients who have a complete response seem to be really doing well. So there will be that group, and the hope is to find that group of patients in our practice. So to conclude about immunotherapy, it does not look like there is going to be a great benefit in the second line. If we are using it, we have to use it in the first line. We have not seen benefits in overall survival to date. Coming to the other agents that are now being tested in triple negative breast cancer. So we talked about antibody drug conjugates in HER2 positive disease. We talked about TDM1. We talked about the trastuzumab deruxtecan. So this is another drug where they looked at this drug in all solid tumors, which included triple negative breast cancers. The name of the drug is sacituzumab, and they found a complete response in 3 patients and partial response in 33 and a stable disease in 40 patients. So basically there was a, considering how heavily treated these patients were, there was a decent amount of clinical benefit rate, we can say, of stable, complete and partial responses. So looking at other ADC combinations also, and trastuzumab deruxtecan is also being looked in these patients who have HER2 low to see what the response rates will be. There is a phase 3 study now of sacituzumab that is going on. Coming to androgen receptor expression, again, by IHC, we see it, these are all very small studies that have been done. And by IHC, the prevalence can be anywhere from 15 to 55% based on which of the case series we are looking at. We discussed that there is a molecular subtype called a luminal androgen receptor subtype, and these patients seem to be having a better prognosis amongst the triple negative patients. So, can we use the agents that we commonly use in prostate cancer, bicalutamide, enzalutamide, abiraterone? And so, these are the drugs that have been used mainly in phase 2 studies, and the clinical benefit rate is there. Again, we don't know which patient will respond and which who won't. So if we have a patient who seems to be having that slow biology, which doesn't look like a very aggressive triple negative, or they're running out of options, definitely worth looking at androgen receptor expression to see if they will get this clinical benefit rate. It is about 20% of the patients. If you're treated for about 6 months, 20% of these patients seem to have some kind of a benefit. So they're not seeing, great complete responses, but stable disease and some partial responses with these drugs. So we can use enzalutamide, we can use abiraterone. They have not been compared to each other, but definitely worth thinking about. Lastly, coming to this pathway, the PIK3 mTOR AKT3 pathway, this was so we talked about this in hormone receptor positive patients and how we are trying to stop the downstream signaling at each one of these levels, and each of these inhibitors have been approved in the hormone receptor positive metastatic breast cancer. Now, in triple negative breast cancer, PIK3CA mutation is the most common mutation that is found. When we looked at the pathways and inhibitors in TNBC, everolimus with chemotherapy, unfortunately, there was no improvement in progression-free survival and overall survival. Upadacitinib was also inferior to chemotherapy. They looked at capivasertib or placebo. Now capivasertib is the AKT inhibitor, right? So when they used that in combination with paclitaxel, there was an improvement in progression-free survival and a numerical improvement in overall survival. A small study and a larger phase 2 data is still awaited, but when they saw the genomic alterations, if the patient had an alteration in the PIK3CA, AKT, or PTEN genes, these patients seem to be benefiting more. So what we are trying to do to conclude is for triple negative breast cancers, we are trying to move beyond chemotherapy into other kinds of treatments to understand the tumor biology better and see who are the patients who will respond to other kinds of therapy. So if a patient has a germline mutation, we can definitely be thinking about in BRCA, we can be thinking about PARP inhibition, we can be thinking about platinum agents. If a patient has a high PD-L1 expression, then immunotherapy is a treatment of choice. Antibody drug conjugates are also being tested and with decent response rates in heavily pretreated patients, and these are moving to the phase 3 studies. And finally, like we discussed, the inhibiting the AKT pathway. So based on each one of that, we can try the inhibitors and see which works and which won't. And hopefully, a few years down the road, we will understand TNBC better and have better tumor treatment options. But as of now, in our setting, unfortunately, chemotherapy remains the main backbone for these patients. And for a few affordable patients, we give the atezolizumab or pembrolizumab. So that was a short class today. Any questions?
Thank you so much, ma'am. It was a wonderful class. Uh, the You may unmute and ask the questions if anybody has any questions.
Okay. So if you have any questions, you can always ask me later on. And thank you for that. I'll be leaving. Thank you.
Thank you so much, ma'am.